afternoon, everyone. This is Joyce Sacco with the Housing Alliance of Pennsylvania. Before we get started with our presentations, we want to provide you with some logistical information. Please make sure you get online while we talk so you can access the visual component of the two presentations. You should have received an email from me this morning with instructions. First, click the ReadyTalk link, enter your name, email address, and click register, and you will be given access to the meeting. If you have any questions throughout the presentation, please type them in using the chat feature on the lower left-hand screen, and we will address the questions at the end of both presentations. Finally, the PowerPoint presentations will be sent out after today's webinar. Again, thank you for joining us for today's webinar. It's part of the Housing Alliance Brown Bag webinar series, where we have a chance to bring today we have a chance to bring speakers from the housing and healthcare field and beyond to share their insight and strategies into new and ongoing initiatives. The Housing Alliance and our members over the past year plus have been in the process of educating ourselves on the movement to bring health and housing together under one roof. We are also excited that the Department of Human Services, under the leadership of Jonathan McVeigh, the Secretary, is leading the charge and has also requested technical assistance from HHS to continue the work around the state to help provide additional opportunities for organizations and individuals across the state. Today, we are excited to bring two incredibly qualified presenters to share their information on the topic. Our first speaker is Patrick Keenan, Director of Consumer Protections and Policy for the Pennsylvania Health Access Network, FAN. Through FAN, Patrick works with partners and stakeholders to build an agenda of health policy issues that improve the quality of care, enhance health outcomes, and lower costs while protecting and expanding on consumer protections and addressing issues of affordability. He also trains organizations and volunteers in best practices for outreach and enrollment in health services. Prior to coming to FAN, Patrick directed a trauma-informed care program that helps at-risk youth learn technical and vocational skills and co-facilitated a National Youth Development Fellowship at the University of Pennsylvania. He holds a Master's of Science in Behavioral Counseling and Criminal Justice from St. Joe's University and a Bachelor of Arts in Political Science from St. Bonaventure's University. We will then hear from Cheryl Winter, the Senior Program Manager of CSH, the Corporation for Supportive Housing's National Consulting Team. Cheryl has knowledge and expertise in supported housing and healthcare integration. As Senior Project Manager, Cheryl provides consulting and technical assistance to help local communities develop and operate supportive housing. Prior to joining CSH, Cheryl worked as the Director of Integrated Health for Pathways of Housing DC, where she managed HealthWorks, a SAMHSA grant-funded integrated care program, and has also served as Director of Quality Improvement at Pathways to Housing DC, overseeing quality assurance and integrated care for Medicaid-funded mental health rehabilitation services. Cheryl holds a master's degree in public health and social work from Washington University in St. Louis, where she focused her studies on the social determinants of health and program evaluation. We are very excited to have Cheryl working on a project in Pennsylvania funded. She's working along with FAN and Robert Wood Johnson Foundation and others, Project Home from Philadelphia, to do a crosswalk. So we are really excited to have them both here. Consider this your crash course on Medicaid, health, and housing. I want to welcome Patrick, who's going to go first. Thanks again for joining us.
Thank you, Joyce. We appreciate the opportunity to talk about healthcare. We think it's probably one of the more important things that goes alongside housing to make sure that someone is in a good situation. So we're excited to give a really high overview of the Medicaid program that's available in Pennsylvania. We've had a lot of changes over the past couple of years, and it's important to kind of understand that it's easier than ever before to access health coverage under Medicaid. And with that new group of people who are entering into the Medicaid system, Cheryl's going to talk about some of the ways in which we can unify their health coverage with housing supportive services. So Pennsylvania Health Access Network, we're a statewide coalition, and our goal is to really engage consumers and bring them into public conversations so that their voices are heard. when we're talking about coverage options in the Commonwealth. We are also a navigator. We are, funded to provide assistance in 21 counties, and through our statewide helpline and the work of our staff, we end up reaching folks in about 45 to 48 counties that are kind of seen spread across this map here of Pennsylvania. So I thought it was really important, since many people have been in the human services sector for quite some time, to begin just talking about where we were and what we've gone through before this year. So prior to 2014, Medicaid was a program that, or a series of programs that was really cobbled together but had some really strict rules. And the first thing that, everyone needed to know, that it wasn't enough to be low income. You also had to be in a particular category, whether that was a disabled individual, elderly, pregnant, caregiver to, a small child, or some other categories that Pennsylvania chose to cover. So you had to be both categorical and low income, but you also had a couple more hoops to jump through. So you couldn't have any assets, substantial assets. Most of the time you had to verify a particular medical condition, and often it was time limited, or the renewal process was very hard. So our previous Medicaid system prior to the Affordable Care Act was very confusing and very difficult for people to manage. We didn't make it much easier in 2014 and early 2015 here in Pennsylvania. We initially declined to expand Medicaid under the Affordable Care Act. So during 2014, there were 650,000 people that were, dealing with, that should have had a very easy coverage option under Medicaid expansion, but unfortunately it wasn't that simple. And in 2015, we were dealing with our former Governor Corbett had decided to expand Medicaid in a very complex way. And you can kind of see, we won't be talking about any of the things that are in those boxes above, but, kind of illustrates the complexity. So, it's been a bumpy start. Now, there were, later on in 2015 and now in 2016, Medicaid is much easier. Governor Wolf, when he took office, streamlined the Medicaid system rather than having those, 4 boxes up there in 2 different categories. We unified our Medicaid program for both traditional and expanded categories, and we gave everyone the same high-quality benefits package. What does that mean? It means that our Medicaid benefits package, is really strong. Most care is unrestricted and unlimited with approval. There's not you don't have to sort out, what benefits go to what group of individuals. As long as you're between the ages of 21 and 64, you're getting the same package. There's no monthly premium, so no monthly cost that people are paying, and if they do have any out-of-pocket expenses, they're very low, generally between $1 and $3. This is unusual because previously, care under Medicaid could face a level of complexity as to, counting a certain number of visits that someone might have to a doctor, or, again, getting into those time limits. So the new adult benefits package really removed some of the biggest obstacles that people face, particularly, and since we're going to be, focusing in on the connection with housing here, often we see a strong link between housing and, not just physical health, but behavioral health care in both mental health and the substance use community. And, what we see is a lot of the most onerous limits that were, implemented under previous Medicaid programs have been removed. So I took a little snapshot there of the adult benefits package, as it's published by the state, and you can see right down the hospitalization and mental health and substance use disorder categories, but, it's saying quite clearly that there's no limits. There's another snapshot here of the notices that people received when we did this change, and it came as quite a shock to many individuals that they could now get many kinds of care that had been previously restricted. There are some benefit limits, so basically care is unlimited unless it falls into one of these bullet points under here. They are fairly obscure benefit limits, so they're not things that we really need to cover on, but if you're curious as to what they are, they're all listed out there. So, what's the catch? This sounds great. Well, basically the key criteria is that, someone who's applying has to have income below the limits listed there. There's both a monthly and a yearly limit listed. And you have to be a U.S. citizen or a permanent resident who's been here for longer than 5 years. Beyond that, there's no really other hurdles that someone needs to jump through. The application process we'll talk about a little later on. It can be a little complicated because there's still, some checks that the state's doing. And so luckily there's in-person support and telephone support that someone can connect with in order to make that as easy as possible. So many people, Pennsylvania, as of 2013, made Medicaid managed care mandatory for all participants. So what does that mean? Let's back up a little bit. Previously, Medicaid, when it started, was a fee-for-service system. One payer paid all medical bills. That was the state. It was very similar to Medicare. Pennsylvania began looking at managed care, in 1997, and as of 2013, it's mandatory. The state essentially pays insurance companies, managed care organizations, MCOs. You'll see that used consistently throughout the rest of this presentation, a flat fee of per member per month to act like an HMO. Many of us are, familiar with HMOs in private insurance options. And the only quirk here is that, under this system, we do separate out physical health managed care organizations and behavioral health managed care organizations. We'll state clearly what that looks like, but the physical health managed care organizations do not cover mental health or drug and alcohol except for ambulance services, pharmacy, and emergency room services. So who are the physical health managed care organizations? You can see the map. Basically, it's based on the region that you're in. So, and you can kind of see how the state has grouped these regions together. And underneath each of those regions, you can see the companies that are listed there. So you have, at least 3 options across the state. Most places you have 4. And then some you even have 5 options to choose from. All of those companies, they act like an HMO, and so I think when people, if we keep in mind that care is unrestricted, it's important to mind that there are a series of rules, and those rules are, available to the general public in the form of provider manuals. Those are the manuals that tell everyone, how this care is going to be administered, even though there's no limits. Prior authorization can be required. But it's important to keep in mind that determinations can be appealed, and so all of that information is publicly accessible. I think Medicaid previously was really difficult for people to navigate, so they got into the mindset that, it was just going to be impossible or certain things were blocked, and they really aren't. As a matter of fact, even things that aren't specifically stated are covered can be covered if they're deemed medically necessary. And so we don't have to spend a lot of time on that, but it is, worthwhile to note that, if a good case can be made as to why something is medically necessary, generally a trained individual in Medicaid can help that client make sure that that expense is paid for or that that service is rendered. One last note on the physical health side. So, they are HMOs, and you should see that they have separate companies to manage dental benefits and pharmaceutical benefits. So it's just kind of noting that, you may have one company, but you may be dealing with multiple companies as you go out to seek out care. There are limited dental benefits in the adult benefits package, and it's just good to know that those are out there, but most of them are focused in on preventative kinds of care. So some of the things that people are most interested in, like root canals and crowns, are still something that there's a lot of groups that are working on to improve the adult benefits package dental component, but this is what we have right now. And the last thing on the physical health side is to get to either physical health or behavioral health services. Medicaid also provides transportation. So each county has a different company that provides that transportation service, but they will take you to and from, Medicaid services. And, there's even the possibility of getting same-day rides for urgent care. So it's a good thing to keep in mind. often transportation is a big barrier for folks when they're going out to seek care. On the behavioral health side of things, so the map is a little different. It's not the region that's so important. It's basically that each county has one behavioral health managed care organization covering it. There are 5 companies that cover the Commonwealth, and so you can kind of see them listed out there, the largest one being Community Care Behavioral Health Organization, that's purple. Folks in southeastern Pennsylvania, are familiar with either Community Behavioral Health or Magellan, and then Value in the center part of the state, the red that's there, and then back out in western Pennsylvania, we've got, Value Behavioral Health. So all the, we mentioned this difference between behavioral health and physical health. So behavioral health, is required to cover all of the services listed out on this pretty lengthy list, diagnostic assessment, referral, and treatment services. So these are the required benefits the recipients, have, and then each county can be a bit different. In order to be more innovative and kind of adapt the system to the particular local needs, behavioral health managed care organizations can choose to include certain supplemental services that would, augment the funding that's coming through maybe a county council on alcohol and substance use or a county council on mental health. So the behavioral health organization can choose to include certain services, that are supplemental to that benefits package. And the state is very clear on what some of those supplemental services may include. This is not an all-inclusive list. But the one that I want to point out is the one that's listed there that's underlined, assistance in obtaining and retaining housing, employment, and income supports to meet basic needs. So this is kind of setting the stage for what Cheryl's going to talk about how Medicaid could pay for supportive housing services. It's actually already listed out there as something that the behavioral health managed care organizations could include. So that's exciting, and Cheryl's going to take us, way down into the details about how, that actually works. So a couple of notes in closing, and I hope that this was a sufficient high-level overview of, the benefits package that are being offered. I think that I wanted to kind of just wrap up on a couple of, technical notes. So there's a lot of different social service providers here, and I'm sure many of the members of your staff are totally, able to do Medicaid applications. There are some communities there that still face particularly high rates of denial, so I wanted to point those out. Our number is listed there as a navigator. We're happy to help anyone if they're encountering hurdles that they just can't seem to overcome. It's really important to know that, folks that are doing these applications, some of the rules have changed with the expansion, so if anyone in your organization is interested in reaching out, I'd be happy to go into more detail on that so that they could get those applications processed in a more efficient way. Another positive thing that I wanted to kind of highlight is that the state has opened up a customer service center that is really great at responding to the needs of individuals calling in. It is important to kind of keep a record of the detail, the times that you've called in there, but tickets are sent to the local county assistance office so that, many people are eligible for expansion don't have the time to go to the county assistance office and, wait to speak with a caseworker. This is a great way of facilitating communications between the general public and the state. You do, on the physical health side of things, have to pick an MCO. Otherwise, you're automatically assigned one. Managed care is not optional, so you have to make a choice. But the good news is you can change your physical health MCO or your primary doctor at any time throughout the year. You do not have a choice of your behavioral health managed care organization. There is only one per county, and it's determined by the county that you live in. And, it's not a perfect system. Hospitals and doctors may not take all of the MCOs that are out there. The renewal process is something we're just going through, so I don't have a lot of things to state about it right now. We're kind of monitoring it, and it seems to be working. But, Medicaid coverage now only needs to be renewed in the expansion categories once a year, and it's supposed to be a pretty simple process. You get a pre-populated form, you make sure the information is correct, and you send it back to the state. It's just a reminder that, as so many people are joining Medicaid, it's really important that they do report changes to their income or, household composition or where they live throughout the year to keep the state updated and make sure that they don't have any interruptions in coverage. The last thing I want to wrap up on, so we've kind of given a high-level overview of what's happening, and it sounds great. There are some barriers to care. Luckily, there's actually great things that are happening, so we could certainly use better care coordination, especially between, folks with co-occurring physical health and behavioral health issues. Luckily, patient-centered medical homes or the health homes model is coming to Pennsylvania in 2017, so that's one thing that will help, overcome that barrier. And then what we're going to talk about with supportive housing services could also certainly aid in that. Again, there's no statewide plan, so you do have to pick a plan, and so if you need care in multiple venues, that can be problematic. The provider network is limited. We still need to do a lot of work about getting more physical health and behavioral health providers into those networks and expand on those providers that are accepting new patients. And then, many people, again, while there's no limit on the kinds of care that people can receive, it's still, prior authorization is required for many physical health things. And on the behavioral health side, it's often about assessment to make sure that, it's someone that meets the proper criteria for behavioral health services. And we see a lot of issues with assessment. So that being said, I hope that I didn't include too much, but I wanted to give a really high overview of the benefits package, in a 15-minute window. I'm sure there's other questions that are out there, and I'll defer to Joyce as to if we take any of those on air, but my contact information is there. And there's also specific resources that FAN runs for consumers, a helpline number, our statewide helpline, and our statewide helpline email address. And then for those that are actually processing applications, we have a special hotline for them so that if they have a technical question about applications or eligibility, we can try to get them clarity as soon as possible. So, Joyce, thank you again for having us on today, and I hope that was helpful.
No, it was great. Thank you so much. Let's pass it off to Cheryl. And for those of you, we're having some difficulties with the phone lines. We're trying to resolve it now. Thanks. Cheryl?
Hi there. Thanks. Thanks, Joyce, for the intro, and thanks, Patrick, for that great presentation. So as Joyce and Patrick mentioned, my presentation today will offer an intro to supportive housing and then a very basic introduction to Medicaid. And I'll talk briefly about the business case behind Medicaid covering supportive housing services, and then lastly, an introduction into CSH's work with the Pennsylvania Health Access Network and Project Home as we're completing what's known as a Medicaid crosswalk, which is an analysis of what supportive housing services are currently covered by Medicaid, and then what gaps and opportunities exist. So with that, let's get started. So a little bit about CSH. For 20 years, CSH has led the national movement to end chronic homelessness through supportive housing. And now we're also using supportive housing to change the way communities respond to a range of vulnerable people. Supportive housing is a proven intervention, and it uses housing as a platform for services that create opportunities for recovery, personal growth, and lifelong success. And at CSH, it's our mission to advance housing solutions that deliver these three powerful outcomes. So it's our mission to improve the lives of vulnerable people, to maximize public resources, and to build healthy, strong communities. We engage vital public systems to adopt supportive housing, which allows for shifting of public resources. Sorry, having some trouble advancing the slides. And at CSH, we are offering capital, expertise, information, and innovation that allow our partners to use supportive housing to achieve stability, strength, and success for the people in most need. I've included my contact information here, and I want to invite anyone to please reach out to Patrick or me with questions. We've included a lot of information in the slides, and while I'm trying to keep my presentation brief so that we have time for questions, there are a lot of resources here on the slides. So it may look like there are a lot of words, and I won't be reading through the slides. I'll just be touching on pieces. So feel free to reach out to me. Here's my email address. With that, let's move to the introduction to supportive housing. So supportive housing it combines affordable housing with intensive tenancy support services. And those tenancy support services are wraparound services that are voluntary. So the tenant can choose which services they want to participate in, and needs assessment is completed, and an individualized service plan is created with the tenant. So it's tenant-centered, and it's flexible to their changing needs. So here at the diagram you see that affordable housing is in the middle, and then those services that are wraparound are around the affordable housing, but again, they are voluntary services. The housing is affordable, it's permanent, and it's independent. Supportive housing is a nationally recognized best practice. And I think often when we talk about supportive housing as a nationally recognized best practice, we see that as a best practice for individuals who are chronically homeless, but it also is effective and a best practice for individuals that have physical, chronic health conditions, mental health disabilities, co-occurring disorders, people who are exiting from institutions, jails, prisons, and those with chronic mental health and health conditions. It also is a best practice for individuals, families, and youth exiting from the foster care system, transition-age youth as well. As I said earlier, housing is permanent, and so that means it's not transitional housing and it's not time-limited. If a tenant chooses to move out of supportive housing, that is fine, that is their choice because it is tenant-centered, but it is permanent in that as long as that tenant would like to receive permanent supportive housing, they can. Tenants pay no more than 30% of their income, which makes it affordable, and it's independent. So the tenant holds the lease, and with that lease, the normal rights and responsibilities come with it. I touched on the services, so I'll leave this slide here. But again, they are voluntary and flexible to the residents' needs. Supportive housing can look different depending on the setting that it takes place in. So there are single sites, which are buildings that are developed or rehabbed specifically for permanent supportive housing. Then there's the scattered site model, which are rent-subsidized apartments, and those can be scattered all around a city or town. And then there's the integrated model, which are mixed-income buildings with a portion of the units set aside for affordable housing. So here I'm wanting to show the difference between traditional affordable housing and supportive housing, and that clear orange circle is the services. And the services piece is often the most difficult and the least stable to finance. And so that's why what we're talking about today is so exciting. Often those supportive housing services are financed by a plethora of different funding groups. It could be state and local dollars. There may be grant dollars. You could have philanthropic giving for innovative programs that are short-term. And then there are now the benefits that Medicaid offers. Medicaid is a $344 billion budget, and we now know that there are services that are reimbursed, and those services, as Patrick mentioned, those populations are overlapping. So Medicaid services aren't necessarily targeting only one group. So moving into the case for Medicaid, we're not saying that Medicaid should replace service funding, but Medicaid offers an opportunity to fill in the gaps. where right now state funding and other housing funds aren't able to meet all of those needs for services. An intro into very basic Medicaid. I wanted to keep this basic, but the Medicaid state plan is something that you'll hear me talking about over and over, so I wanted to just provide some definitions. The state plan is essentially the contract between the state of Pennsylvania and the Federal Centers for Medicaid and Medicare, which are known as CMS, and it authorizes financial assistance. It is a partnership between the state and federal government jointly funding services. And then in addition to the state Medicaid plan, states and Pennsylvania and CMS, the Centers for Medicaid and Medicare, can agree to provide optional benefits or through waivers, which would be for specific populations that are cost-neutral plans, or through plan amendments. Sometimes you'll hear those called state plan amendments or SPAs. With the Affordable Care Act, health insurance has expanded coverage, which is really exciting, and there are written into the Affordable Care Act paths for new service delivery models and new financing mechanisms that are innovative and that control costs. So we are seeing that providers are moving away from fee-for-service payment mechanisms. We are working to better coordinate care because of the ACA, and to better integrate primary and behavioral health care and now housing services. One of the things that Patrick mentioned was the thresholds and requirements that Medicaid used to have, and now with expansion, how many more people are covered. And that includes nearly all homeless single adults are now included in expansion states. Those income requirements still apply, so that's why I say nearly all homeless single adults. But one of the things that the ACA is looking for is new approaches to cost containment. And so when we're talking about a business case for Medicaid paying for supportive housing services, it's one of those innovative approaches that would promote cost containment while promoting better integrated care and better health outcomes. We know that 5% of Medicaid beneficiaries account for 50% of program costs. So a very small group of people are costing Medicaid a lot of money. And there are ways that we can save on those costs and provide them with better care. That leads us to our business case. So the two projects that CSH is working with the Pennsylvania Health Access Network and Project Home to complete are a business case for the state of Pennsylvania, and then the Medicaid crosswalk. So first I want to walk us through the steps that we're taking for the business case and provide a little bit of the common findings that we have found across the country that provide a national business case. So the steps are that we look at national evidence of cost savings, and then we look at cost data for people with the highest costs in Pennsylvania, and it may be local data or it may be state data, for those who are not stably housed. And then we apply that cost reduction percentage that we know that supportive housing achieves, and then we're able to demonstrate the savings potential. So once we determine the return on investment, we can provide the state and the federal government with the financial justification for why providing supportive housing services through Medicaid would save money and improve care. So this is what we know. We know that housing can determine health outcomes and that housing improves health outcomes. These are 3 studies. I'm not going to read through them, but you can take your time after the presentation to look at the findings are pretty significant. Improved health status, reduction in alcohol use, increased survival rates for people with HIV/AIDS, very significant health outcomes. We also know that housing saves money. It saves Medicaid costs. And these dollar amounts here, I put an asterisk because I wanted to be sure that everyone notices that those dollar amounts are per person per year. And you can see the variation. So in Chicago, it's $25,000 were saved per person per year in this study. In Maine, it was $6,000. So it's important to look state by state. Each state plan is different, and each business case is different. And so that's why we're doing this for Pennsylvania. So where we'll be starting, there are some great examples in Pittsburgh and Philly. There's national data where we need it, and we're going to be evaluating the cost savings and also wanting to engage with all of you to build partnerships. All right, next I will be talking about the Medicaid crosswalk. And as questions are coming in through chat, I'm speeding through this because I want to be sure to have time for questions. If we aren't able to answer all of the questions that are coming in through chat, I do want to be sure to answer them offline, and I can give those answers to Joyce, who can make sure to get them to you.
If I could interject before you go to the next slide, I also wanted to let people know, it's Joyce, that at the end of the webinar there'll be a survey, and we're really interested. I know you're going to talk about a meeting that you're going to host with Patrick the end of next week. But if people have like part 2 of this they would like to do, the Housing Alliance, I know FAN and CSH and others on the phone are interested in continuing this. So please throughout think about what part 2 might look like and how we can help make that happen. So
great.
Thanks.
Thank you, Joyce. Thank you. So for this next section, I actually include dates because I want, well, to share my excitement for what we're working on and also to give you an idea of a timeline. So in the next month, we're going to be completing our comparison of the supportive housing services with Pennsylvania state plan, Pennsylvania's Medicaid waivers, and looking at those behavioral health managed care organizations that Patrick was talking about, looking at the covered services that they're providing. And then we also are going to be completing interviews with agencies that are supportive housing agencies in Pennsylvania, whether they're Medicaid billers right now or not yet. We'd like to hear from you. This list here is the supportive housing services that we are looking at and comparing the plan when we do that crosswalk. I won't read through all of them, but in a moment I'll talk about some of the common alignment that we find as we perform crosswalks and some of the common gaps. So by the end of March, we'll have a good assessment of what can be billed now. If you were to want to start billing Medicaid for supportive housing services, what is right now in the plan, and what gaps exist. And then our crosswalk report, which will include recommendations and an overall analysis of everything that we've looked at, will be ready by the end of May. Then the business case will be complete by the end of June. And what we commonly find is that there are, normally in states, there are ways to currently bill for supportive housing services. Not necessarily all that were on that chart, but there are some services that you could be currently billing for. And we also are often finding that contracting with behavioral health managed care organizations often provides the most comprehensive coverage. They are looking for ways to provide better care, and improve health outcomes, and save money. And so contracting with behavioral health managed care organizations is to the benefit of the consumer, the managed care organization, and the provider. And then we also are finding that some services are covered through those waivers, the home and community-based services waivers. Some of the common gaps, so services that aren't necessarily covered, and again, this is not what we have found yet for Pennsylvania because we are currently working on the crosswalk, but these are common gaps we found in other states. That some tenancy supports, transportation, the pre-tenancy support, so working with someone on paperwork, helping them to get their ID and everything for the housing application, meeting with the landlords, going to view units. Some of those services are not currently covered. Also, one of the gaps is licensing and credentialing. So supportive housing providers may be providing excellent supportive housing services and have been doing that for decades, but may not have the licensing and credentialing or behavioral health training that is required by some of the state plans. Some common steps we've seen other states take is after having the crosswalk and the business case. Many providers then want to better understand what it would take to become a billing agency or to contract with a BHO. What qualifications would they need? What licensure or certification would be required? And so then often the state and advocates are then looking to assess interest in the provider community to then be able to build and deliver a supportive housing Medicaid Academy, which is a service that CSH does. And the Medicaid Academy then helps providers to walk through those steps of becoming a billing agency and to create their business model for their agency. I've included these resources here, and I think that they will answer probably some of the questions that will be asked today, so I may refer to some of these as we're answering questions, but there are others, there's a plethora of resources out there, and so I may give Joyce a list so that we can be sure that you have everything you need to best understand this topic. Finally, I'd like to hand it back over to Patrick to talk about how you can all be more involved in the call that's happening next week.
Great. So thank you, Cheryl, for going through those things. I think that, this is, if anything, this is a really packed hour, and so what we wanted to do is have at least a place to continue the conversation, specifically around, Medicaid as it currently is, as we understand the physical health and behavioral health side, and how, we could see some of those supports moving over, by pursuing supportive housing services. So we've scheduled a call a week from today on Friday, February 5th, from 2 to 3. There is a link. We would appreciate it if you could register, for that call, just so we have a sense of who's interested in participating. And we'll be sending out a general agenda, and also, based on the results that we get from Joyce's survey that she mentioned that she'll be sending out, we may ask some follow-up questions to make that call the most effective. But we wanted to have a place for people who are interested in helping us take the next step. Everything that CSH is doing is going to be really important to substantiating the need for supportive housing services. But, those numbers and that data, is going to be most effective when it's backed up by folks, like all of you that want to see this become a reality here in Pennsylvania. So that call will be the first, starting point for it. I also should say that there's a lot of questions about community health choices. Really briefly, people who are receiving long-term services and supports through Medicaid, previously through waiver programs, are going to be moved over to managed care. I think that there will be more discussion of that with the housing community, especially as more details are made public. I think that so we should probably kind of talk to Joyce about maybe promoting some more educational opportunities about that, because that's a really specific community. But we kind of talked on Medicaid broadly today, so it's not that we're not addressing community health choices. That's a kind of separate thing unto itself.
We'll pass it off to Tori Beret from the Housing Alliance. She's going to go through the questions that people have typed in, and then after that, if you have questions, to unmute, do *7. Tori?
Hi, everybody. So I have one question here from Kenneth Bigos. For people that are on Medicaid and have United Healthcare Community Plan, they need to check in advance if that hospital or doctor accepts that type of insurance. What if they went to urgent care or to the emergency room and learned that the provider is not included in the network?
So emergency care, the the great part about the adult benefits package is so urgent care is separate. Emergency services, however, are available, regardless. So really without respect to network. So you can go, if you're having a true emergency, then you can go and be seen by the ER. For other issues, though, doctors do have to accept it. With urgent care, it can be really questionable as to whether or not a particular plan is going to, see it. Generally, that urgent care will tell them, they can't see them if they don't accept that kind of coverage, and they'll redirect them to the emergency room.
We have a question from Melissa Bemmer. As service dollars are decreasing in Philadelphia through HUD and DBH, and Medicaid is moving away from fee-for-service funding, how can agencies continue to provide and finance services to those in permanent supportive housing?
That's a great question. Melissa, that is exactly what the crosswalk is looking to provide recommendations to. And while Medicaid is moving away from fee-for-service funding, it's not moving away from funding, and so it may look like a case rate. It may look like a daily rate for each person that you're providing services to, or a monthly rate, which allows you to have flexibility in what services you provide and how you provide them to individuals. But moving away from the fee-for-service would mean that you're moving away from being paid in units or being paid for each activity, and rather you're being paid at a rate for all of the services. But that's definitely something that we'll want to address in writing in the crosswalk, so thank you for that question.
We have another one from Kenneth Bigos. Do you think Medicaid can address the condition and quality of housing and possibly have Medicaid pay for repairs to private homes if that results in improved health outcomes? Example, a family with asthma that has a house with mold, instead of paying for their medical room visits, can they pay for a contractor to fix the mold?
Okay, so I've never heard of Medicaid paying for repairs, the actual repair costs, but one of the things that a supportive housing services would allow for is that if that family is receiving supportive housing services, part of those services are advocacy with the tenant and assisting in relationship navigation with the landlord. And so if there is mold that is contributing to asthma in the house, that is related to the landlord's responsibilities and the tenant's rights. And so supportive housing services would support the tenant in understanding their rights, that they have a right to live in a mold-free unit, to make sure that it's a safe unit for them, and then to help them in navigating what it would take to communicate that to the landlord and providing services as they navigate through that process. So it wouldn't pay for the actual repairs, but it could assist them in having the landlord make those repairs as they navigate that relationship.
We have one from Lori Wolf. If someone currently receives community-based waiver assistance, can they receive additional supports under a BMO?
So that's a really good question. I think that we're going to, and that's why we kind of mentioned community health choices coming down the pipeline for people, under waiver services. So we're moving away from waivers into managed care. So that's going to change things. If someone was potentially enrolled in both, a waiver program and Medicaid, that would be very weird. But I mean, there's things that can happen. Then it's possible, but most of the, waiver is generally a fee-for-service model, which kind of is separated out from what the BMO provides. So generally no, but there's some ways it could happen.
Okay, we have one from Ricardo Benitez. Does Medicaid supportive housing include Medicare, Medicaid, dual eligible individuals?
So this is Cheryl. So providers can choose to serve both Medicare and Medicaid individuals and dual eligibles. So there are supportive housing providers that serve both, yes.
Okay. And from Ann Torregrosa, have you approached the Wolf administration about this? How open do they seem to it?
So yeah, I mean, and Joyce can kind of chime in here too because she's got a great working relationship. So I think that the administration has been very open. They're pursuing the technical assistance that's available out there on this. So they are, interested in learning more, and they're taking an active approach. I think the biggest thing right now is to kind of see how we could, if the state was awarded technical assistance, what are the ways in which these two projects can kind of work together and complement each other to really strengthen the case for supportive housing. And as Joyce mentioned in the beginning, Jonathan has been nothing but excellent on, listening to folks, learning more about this, and speaking with advocates. So we're really excited about the possibilities that could happen.
Absolutely. I would echo what Patrick said. This is Joyce. In addition, DHS contracted out to do it, or they have a position paper. I think that's actually not the right word, but a report that I think is in the governor's office that they're going to hopefully release on what they hope to work on. And this piece is definitely front and center. So I don't want to speak for them, but I think, as Patrick said, I think they're on board with educating themselves, working with us, going forward. So
great, and that is, we have one other question. What if an owner-occupied unit has a mold problem? Is there a way for Medicaid to assist in repairs? And this is from Armin McNally.
So I think that most of the time, I think it kind of circles back to what what Cheryl said, is that it would be hard. So generally, Medicaid Medicaid from the federal dollars has made a very clear line in the sand that the federal dollars will not pay for directly for housing or writing out a rent check or doing anything else with Medicaid dollars to pay for the structure itself that houses someone. There are unique programs. I mean, New York, New York is different in many ways, but they have programs where you can actually get rental assistance through state Medicaid dollars that are saved by pursuing other innovative cost-saving measures. So it's not totally out of the ballpark, but it's really at this point, I think supportive housing services would be the first step, and then if there's any potential to do anything else more broadly, it's not on the table right now.
Mm-hmm. Yeah, and I would say there is a great document that was put out that it's the third bullet point. Let me see if I can switch the screen. Let's see. Okay, so the information bulletin on tenancy supports, I'm not sure if it'll let me take us to it. It won't. That answers questions and provides clarity about which housing support services, the difference between housing support services and then covering housing costs like rent subsidies and repairs, that those are not covered by Medicaid, as Patrick said. I will say, though, again, the advocacy with landlords and education on tenancy rights, which is a right to have safe housing, that is a part of tenancy supports under supportive housing services. So the case manager could work with the individual on that piece of it.
Great. That's all we have for questions. Joyce, back to you.
Thanks, Tori. Does anyone else on the call want to unmute by doing *7 and asking a question? Do we have someone who has a question?
Hi, this is Jeff from PA. So can you hear me?
Yes.
Yes.
Have you seen a copy of the governor's proposed housing plan yet for DHS populations?
That's actually what I just talked about, Jeff. My understanding is it's still on the governor's desk. So from the Housing Alliance perspective, we haven't seen it. I don't know if other people have, but I think it's still waiting final approval.
Okay,
I agree with Joyce.
that might be something to maybe do a webinar on or something in the future, though.
Definitely. Jonathan was on the Homeless Provider Network call 2 weeks ago, and we offered that, and he's definitely on board with doing it. So, yep, we got it in the mix.
Yeah, and once Community Health Choices come out, maybe something on housing, because that's going to be a very big piece for not just folks under 60, but for seniors getting into the OLTL system through managed care. Thanks.
And Jeff, I really just appreciate you bringing up, Community Health Choices. It's going to be a really big change. Pennsylvania, the administration is really excited about it and is convinced that, it's going to have a really solid plan. And I think as those details come out, we're interested in seeing, what kind of impact that's going to have on the community and just making sure that, we're, that it has that, it's achieving the goals that it's stating. So we're cautiously optimistic and excited to kind of see more of that come out. So as more details are there in Community Health Choices, I definitely think that would be something that housing folks would be interested in.
Okay, thanks.
Hello, this is Connie Caraso from Bucks County Women's Advocacy Coalition. Can you
Hi, Connie.
hear me?
Yes,
Hi.
you can. Go ahead.
I'm on your website now on CESH, and I see that you offer trainings and workshops. If our coalition wanted to promote a training for all the providers in Bucks County that this would pertain to, would there be opportunities to bring you folks in?
Absolutely, and my email it's in one of the beginning few slides, so please feel free to reach out and email to me.
Okay, thank you.
Thank you, yeah.
Good afternoon. This is Natalia Gomez from the Community Justice Project out in the Hazleton area.
Thank you. Go ahead.
And I was wondering, especially for the CSH folks, in this area we're seeing, especially in the Hazleton area, the most vulnerable, the homeless, there's no really specific shelters, or for the DV victims, the shelters are out in another town where there's hardly any car transportations and stuff. Is there any specific target area where you might be trying a pilot project to see how things are being done, or what is being offered, or what's going to be offered in these areas?
That's a great question. Are you able to be on the call next week? I would love to, if we could email, and then I can connect you with our folks that are working in Pennsylvania on the ground.
Okay, yes, I will definitely try to be there, because it's a big issue here. I can tell you of cases where individuals that did not have places to stay, where they will be allowed to go and stay at the only facility that might allow them to stay, but 6 o'clock in the morning, whether it's 20 degrees or 10 degrees below zero, they're kicked out to roam in the street.
Yeah, and one of the exciting, sorry, go ahead.
I just also wanted to say, can you tell me your name again?
Natalia Gomez from the Community Justice Project out of the Hazleton office.
Great.
Thank
Thanks,
you, Natalia.
You know what? I will make sure that if hopefully you can make it. If not, I'll make sure that Cheryl and her people get your contact info.
Thank you.
Thank you.
We had actually one more question from Helen Kelly. Are bed bugs considered to be in the same category as mold in terms of health hazards, which cannot directly be paid for with Medicaid dollars to resolve, but only through advocacy support?
That would, yes. That would be a landlord responsibility, and absolutely a tenant right for a safe unit.
This has been really, really helpful. I want to thank Tori for running it, and also Cheryl and Patrick. Very informative. And again, the survey will be coming. Please let us know You can do the survey, email, call. You have contact information from both presenters and us at the Housing Alliance. Again, we want to provide as many opportunities for the folks on the phone to do the great work you do throughout Pennsylvania. So again, thank you, Patrick and Cheryl and the group for getting on today.
Thanks, everyone.
Bye.
Yeah.
Thank you.
Bye-bye.